Hello and welcome to Rural Doctors. I'm Jerry Gannon. Thanks for joining us. In this program on women's health, we'll speak with Dr Narelle Hadlow about ovulation tracking. And we'll hear from Carolyn Wall about resources being offered by Jean Hales. But first, let's join Dr Olga Ward, who's speaking with Dr Susan Downs and Dr Robyn Leake.
Well, Susan and Robyn, welcome to the program.
Thank you.
Could we today talk about antenatal care to start with, and particularly the massive confusion that there is for patients with the myriads of supplements that seem to be around? What should we be taking? Every few months there's a new debate about vitamin D, or should they get iodine, and how much iodine should they get? And then, of course, there's the long-term folic acid thing that's well and truly ingrained in Australian doctors and patients. Where do the patients go for good advice?
Well, pregnancy starts before pregnancy, or pregnancy advice starts well before pregnancy, because the women need to be fit and well before they conceive. The folate has been around for a very long time, since the Scottish studies where everybody was eating potatoes and no green leafy vegetables, and there was a high rate of neural tube defects detected, and they figured it out that it was the folic acid. So rarely do you see neural tube defects these days, because almost everybody knows about folic acid prior to pregnancy.
As long as they're actually planning to become pregnant.
As long as, yes.
Don't accidentally become pregnant.
Exactly. But so really you should be taking it for 3 months or so before you fall pregnant, and for the first 12 to 14 weeks of pregnancy. But if people tend to know that they're pregnant quite early on, to some extent these days, and so to start it as soon as they fall pregnant is, at least it's not too late, but it would be more ideal if they had pre-pregnancy counselling and they started much earlier. Yeah. Vitamin D, iodine, omega-3, all these things have come out, but certainly vitamin D has, certainly in the Kimberley, we're very serious about vitamin D. Iodine is the latest one, and there is lots of thought that women should be taking in pregnancy, prior to pregnancy and during the whole of pregnancy, and after for breastfeeding as well, that they should be taking vitamin D and iodine.
Robyn, is that your experience with your patients?
Yep. Certainly the evidence for iodine supplementation is fairly compelling. Australia is an ancient continent, and our soils don't have much iodine left in them, and people eat less and less iodised salt in their diet, which is a good thing. And certainly iodine deficiency is a preventable cause of mental retardation in the baby. So I think it's it's a good advice.
Yeah. Now, what about vitamin D? I mean, as country doctors, our patients don't like sunshine, but obviously ingested vitamin D is the problem for the sunshine to work on. What should we be asking them to include in their diets, or are they just simply going to swallow another capsule?
Mainly from fish, isn't it?
And veggies. It's oily fish, which the vast majority of the population are not having in desert population or Aboriginal population, but fortified breads and fortified dairy produce has vitamin D in it. But as far as the sunshine, certainly the sun comes out of the sky, but people these days stay out of the sun. They put slip, slop, slap on. They tend to cover up. Indigenous women, their life is mostly in the night and the evening. They tend to sleep in during the day, and they don't tend to go out as much. Their style has changed. And so whilst there's lots of sunshine, lots of warmth, with the black skin as well being not absorbing the rays to convert for vitamin D in the skin, a vast majority of them are actually vitamin D deficient. And we're treating more, seem to be picking up, it's a routine screening test now, and we're picking up more and more quite severe depletions.
So it would be something to put into our antenatal screening before or our pregnancy planning screening, along with the, are they immune to rubella and are they immune to varicella?
Yes.
Yep.
Yeah.
I think too there's some individual variations in metabolism of vitamin D, because you certainly see individuals who spend plenty of time in the sun, more than the recommended amount, and they still have very poor levels. So there must be some individual enzymatic problems potentially.
Yeah.
And also, if you're having vitamin D, you also need a calcium intake, and you know, calcium in dairy products is not something that Indigenous people have naturally in their diet. You know, yogurt and cheese doesn't come into their diet greatly. A bit of milk
and
does,
huge amounts of green vegetables don't either, do they?
And huge amount of green vegetables don't. So they are at a particular risk. And seafood doesn't come into their diet greatly either.
Not if you live in the desert.
No.
What does a vitamin D deficiency do to the baby?
Potentially it can, it's all to do with bones, and potentially it can cause rickets in the baby, and osteomalacia and osteoporosis in the mother.
Yeah.
I've seen certainly bandy-legged babies, and I've seen full-grown rickets, but it's not huge, so they obviously must be getting something. But
it's not huge, but it's completely preventable, and it's a tragedy that a kid gets it at all. Yeah?
Absolutely, and for the long-term thing, being pregnant takes away a lot of your calcium and nutrients, and so for women having more and more babies, they're going to get more and more vitamin D and more effects. So as they get older, they're going to get more and more osteoporotic. So it's a way of picking it up now and preventing things in the baby and for the mother later.
So it sounds to me like a pregnancy supplement should contain some calcium, some vitamin D,
yes,
some folic acid,
yes,
probably some iron, because they're all pretty much iron deficient,
and probably
some iodine, and some omega-3 for
the brains,
for the brain, just for fetal brain development.
Yes, and asthma reduction, doesn't it do that as well?
Well, quite possibly.
Yes.
I don't know. If it treats placenta brain, then I think the women would swallow it gladly.
No, for the baby's brain.
Is there a supplement that magically contains all of these things, or are the ladies going to be doomed to medicalise their pregnancy with 5 capsules a day?
Well, sometimes it's 4 capsules of vitamin D if they're severely deficient. There are various companies that put out the cocktail.
Yeah. I've always looked at some of these pregnancy multivitamins and thought they seem to be very homeopathic levels of all of these.
Especially the folate.
You'd have to, the folate seems to be grossly under.
Well, folate's a particular thing because it comes in 0.5 or 5, so it's.
But you know, quite often those multi-pregnancy multivitamins have 0.2.
Yes.
And I'm thinking, why bother?
Yes, that's right.
I suppose then they have to buy several supplements. Vitamin D ain't on the PBS.
No, it's not.
How do our Indigenous patients from the desert,
the AMS
manager, they can stock it?
The AMS is certainly pushing vitamin D, yes.
And what about the rest of the supplements as well?
The iodine business is only relatively new, and certainly I haven't seen that being handed out greatly, but I've been recommending it, but you can buy it at the supermarket, but again it's all very expensive.
Is there as I said, a magic product that contains all of these? I know we're not supposed to mention product names, but if there's one that does the lot.
There is a Blackmore's pre-pregnancy one that has got pretty well the right things in for the right time.
In the right doses? Yeah. So I guess we could recommend that if we wanted them to just take like one thing. I'm thinking, I know my pre-pregnancy patients are usually very motivated and very keen to have a healthy baby. Some of them are even motivated and keen enough to try and give up smoking and drinking, which is terrific. But
see, the other thing,
a handful of tablets.
The iodine for the baby's IQ, we're dealing with a population that has quite a lot of alcohol and fetal alcohol syndrome as well. So I think we should be really, really enforcing that we give them that information, because we're down on. We're really trying to cut out smoking. We're really trying to get them to have 0 alcohol, and if we can prevent other things that cause low IQ, and they are likely to be low in iodine. We've got a diet low in iodine. They used to apparently, the milk used to be washed out with iodine the pans and things.
Yeah,
antiseptic
used to be iodine. That's how we all got our iodine.
And that's how we used to get our iodine. And since they now don't do that down the dairy, the milk has got less iodine in. So that's gone, and just generally our soils and things have all been leached away. So we need about 250 micrograms of iodine for a pregnant woman per day. And they're only getting about half that, so they recommend that everybody gets 150 micrograms extra, which makes that up, because the only source is oral, the only source for the baby is through the placenta, and then during pregnancy anyway, the thyroid has to produce it works at about another 150% of its normal state. So pregnancy is a very hyperthyroid state, and you need more thyroxine just to build that to continue with the pregnancy. And the baby doesn't get, a baby's thyroid doesn't start to work until really close to delivery.
So it sounds like iodine supplements are again something that we're going to need to work, particularly with the Aboriginal Medical Services, to get something on board as a regular supplement.
And particularly to recommend people that actually are hypothyroid before they start, because if they're not recognised, then they're going to have increasing problems during their pregnancy. But you have to be careful. Obviously, you don't get iodine substances to people that are hyperthyroid.
Well, we've talked about screening our patients pre-pregnancy. What other kinds of things do you screen for on a regular basis?
Pre-pregnancy? Certainly varicella, rubella, chlamydia, gonorrhea, syphilis. Whether they're anemic, their iron studies.
What do you think about vaccinations during pregnancy, particularly flu vaccination, which is being pushed quite heavily now? But
it's certainly been pushed for the pregnant women, because during the flu outbreak there were quite some serious cases that were for pregnant women. I think with any vaccination it's quite frightening to offer vaccinations to women, but that certainly is the thrust of the campaign, and I just give women the choice.
The most recent suggestion from our college meeting I went to a few weeks ago was that pregnant women be definitely recommended to have the flu vax, and the one, forgive my ignorance, but the one that was less associated with adverse reactions that's being offered to the children this year is the one that's also being offered to pregnant women.
And
through the public.
Yes, it's a brand, and I think that's the VaxiGrip brand rather than the FluVax brand. Unfortunately, not the CSL Australian brand, which did have the reactions, but fair enough. It seems that flu vaccination is at least relatively safe in pregnancy. What about other vaccinations during pregnancy, particularly if you, say, found somebody who was not immune to varicella or not immune to rubella, and who, as commonly happens, is a primary teacher with 3 little toddlers at home already?
It's absolutely contraindicated in pregnancy and must not be given.
They're live attenuated viruses and vaccinations, and they should not be given.
So we'd be reading the product information and looking up the schedule.
But if you've got young people, and you can always test them well prior whilst they're on contraception, and that's the best time to vaccinate them.
Yeah, and otherwise tell them to take precautions.
Yes.
What would happen if somebody, like I'm thinking the hypothetical primary teacher, contracted, I mean mostly it's varicella these days because you don't see a great deal of rubella, but what would happen if she contracted varicella during pregnancy? Can you do anything?
The greatest risk to the fetus is in the first trimester of pregnancy with varicella. So if they're in trimester 2, the risk of the fetus being affected adversely is very low. So the main risks are to the mother. In trimester 3, the mother is at more risk of respiratory compromise because of her gravid state. And unfortunately, if the babe's born with active varicella, they can become very, very unwell. Not that you can do anything about that. If labour's imminent, but it's something that does concern us.
Can you treat it with antivirals? Will that make a difference?
It can be treated with antivirals, and certainly if a mother was having respiratory compromise from varicella, absolutely should be given antivirals.
Say if you're in a remote community or a rural community and you have your hypothetical primary teacher 10 weeks pregnant, comes down with a roaring case of chicken pox, and comes in to see you, how would you manage that?
I think you'd need to treat the mother on her merits. So if she was unwell enough to warrant antivirals, you'd give them.
Yep.
In terms of surveillance of the pregnancy, I'd be seeking tertiary level ultrasound surveillance of that fetus.
Yeah. And Sue, would you do anything different?
Yeah, I would do the same.
IV antivirals, like sort of intravenous acyclovir, or can you give just the oral things in the shingles dose?
I think it depend on how sick she was.
Yes.
If she was that sick that you thought she needed IV, she'd probably be best shipped out for respiratory support and then IV. But for most patients it would be oral, I would imagine.
Yeah.
Fortunately, chickenpox is something that most people get when they're young. And most women, even if they can't remember that they've ever had chickenpox, when you test them, that they are covered. And women, people that go to work in those remote places usually test themselves for mumps, measles, rubella and chickenpox before they go, and they get those vaccinations before they go out there.
So that's something that maybe the education department recommends to teachers who are going out to rural communities?
Certainly medical staff, nurses and doctors are all tested before they work for the health department.
Yeah.
And before we leave screening, something that causes me a lot of angst in explaining, and my patients a lot of angst, is the first trimester screen, the 10-week blood test and the 12-week ultrasound. Could you maybe run us through how you explain this to a patient and what happens to, say, a 25-year-old who comes back with something that says high risk?
I think you try and offer it to them, and certainly it's a very, very important test. Often people present too late because that one at 10 to 13 weeks, that's often too early for a lot of people to realise that they're pregnant, or at least present for the pregnancy. But I always say that these tests are available, that they are screening tests, that they are not tests that tell you that you've actually got this, that they put you in a high risk or a low risk group, and that there are two tests that we've got. One is in the first trimester and the other is in the second trimester. One is slightly more accurate. The first trimester test is about 90%, so 10% won't be detected, and the other is 85 to 90.
And you're talking about the triple test.
The triple test in the next one.
Yeah.
The first one involves a blood test, followed by or at the same time as a detailed ultrasound, and you can't get that particular ultrasound just at every place. You've got to be a specialist centre. We've now got somebody in Derby that will do them, so that's been a great boon for us.
We can have it done in Merredin, so...
Yes.
Is there a centre out towards you in Wallona, Robyn?
Nope.
No? So where do those patients travel?
Do they get PATs to Perth for that?
No.
I don't think they get
No.
PATs, no,
No,
unless they are at a high risk, unless they were of greater age.
They get PATs for their 20-week visit, but not
for screening.
So for those women that are not close or not able to attend for the nuchal fold in the first trimester, then they've got the second trimester test, the triple test, which has two disadvantages. One, that it's slightly less accurate, and one, that it's done at a different time, between 15 and 17 weeks.
Yeah.
So by the time you get the result back from that, women are much further down the track, and by the time we can organise an amniocentesis, which is the next step. If you come back as positive or high risk, or in the higher risk section of these two tests, what are you going to do? You can do nothing and say, well, I know that I'm high and I'll take my chances. You can say, I'd like to go on to the next test, which is amniocentesis.
What's the risk of losing a pregnancy with an amnio?
With an amnio, it's 1% or less these days, plus the normal risk of baby being lost. So it's really a low risk to have an amniocentesis. It used to be higher, but these days it's much better.
Yeah. However, you've got then these women who've got a 1 in 150 chance of having a baby that's abnormal on their nuchal fold and blood test. and they've got a 1 in 100 chance of losing the baby, doing the definitive test to find out whether or not their 149 to 1 chance of having a normal baby was right.
Some people...
It's hard, isn't it?
Some people just say, oh, I want everything. And some people say, I don't want to know. I mean, they've got the right to refuse these tests in the first place. But you do need to explain what a screening test is, that it's a screening test, it's not a definitive test, and that there are stages after this screening test should you want to go further.
When does one normally do an amniocentesis? At what gestation is it?
It shouldn't be done before 15 weeks because the risk of amniotic banding and other such catastrophes is higher. So generally it's around 15 to 16 weeks. However, a CVS can be done earlier.
Yes.
And CVS isn't really all that widely available these days?
In Perth it is.
In Perth it is.
In Perth it is, and also, but CVS is about 10 weeks, isn't it?
Any time from about 10 weeks onwards,
Yes.
Yep.
So a lot of people don't know that they're even pregnant by that time, so they often miss that. But it's got a greater risk of miscarriage, probably 3 or 4%, rather than the 1% with the amnio.
Yeah.
It also isn't quite as accurate.
So by the time the woman's got a positive abnormal result, like a real abnormal result on their amnio, they get their full genetic complement of their baby. They find out that it's, say, a little boy with Down syndrome, they'd be like 19 weeks pregnant.
It can be.
What happens to them if they decide to terminate at that stage?
Well, they need counselling, of course, and that is available at King Edward. Termination in Western Australia for anybody is 20 weeks, but there can be terminations over 20 weeks that have to go to the special board for fetal abnormalities. So it's really nice if you can get it less than 20 weeks. You can pick up these abnormalities less than 20 weeks, and that obviously if the women patients, you can never really predict exactly how they're going to feel. Some people say, oh, that's fine, at least I know I've got that to look out for, and that I will continue with this pregnancy and I will take that on board. These days, the medicine with Down's babies is fine, they've got normal life span, etc. It's not as severe as it used to be, and that's what I'm going to do. And then you have the other extreme that say, I don't want anything with any abnormalities. Yes, please direct me to have a termination. And there's a great range within those people. It's the people that can't decide that it's the biggest problem.
Yeah. Robyn, what would you normally talk about with a patient if they were asking about terminating a pregnancy?
Early or later?
Either.
Either, okay. Well, by law, one needs to discuss with patients the risks of the actual procedure, and one is also obliged to talk about the risks of ongoing pregnancy.
And you need 2 doctors.
Yep, you need 2. So one needs to do that, and then the second person needs to do the same. The person doing the termination cannot be the only counsellor. There needs to be 2. And that's by law in Australia, in WA. As long as you fulfil those criteria, then termination in this state is completely legal under 20 weeks.
Yep. So I could, as a remote area GP, I could talk that through then with my patient, talking about the risks and the benefits and the emotional risks as well. And then refer them to a clinic or a specialist or whatever.
Who will go through
the same stuff again, and that will fulfil the legal requirements for 2 doctors?
Correct. Yes. So you've got to say the risks of having a termination versus the risks of having a pregnancy and a birth. The risks of having a pregnancy and birth are quite high.
Yeah.
You've also the psychological risks, the risks of anaesthetic, all those things.
How do you talk them through that whole psychological aspect of terminating?
It's a big thing for women. Some women are absolutely adamant that this is what they want, and then there's other people that are very equivocal. You've still got to say exactly about the risks of each way, and say that they're likely to get sort of depression or anxiety that can be leading up to the procedure, after the procedure, especially annual events, or if they see other babies in prams and think, oh, that could have been me, etc. It can be ongoing, but there is certainly, and as far as the counselling is concerned, you've got to tell women that there is further counselling available, especially for that. You've got to invite them and make sure that they know that that's available.
Do they get a real hormone baby blues pregnancy drop, you know, from being pregnant to not being pregnant?
I don't know whether it's hormonal, but there's certainly anecdotal there. People do.
Day 2 or 3 when it hits home?
Yes, yes. And leading up to it, am I doing the right thing? That sort of thing. And why am I doing it? Are they being forced to do it by a partner or by parents or whatever, or are they doing it for their own reasons?
Do you ever talk through with them how the termination is done?
Yes, I do.
Because at a later stage they have to actually labour out the fetus, don't they? And particularly if you've got a very abnormal baby that, say, is 20 or so weeks.
Well, you're talking about two different things. If you're just going for a suction D&C under
12
13 weeks or 12 weeks or so, then I talk to them about what happens in theatre and what we do, and that it's, you know, and
that enables you to talk about the risks too.
And then you talk about the risks of perforation of the uterus, the anaesthetics, bleeding, infection, the works, all those sort of things. But if you're talking about actually going through a mini delivery, then that's quite traumatic.
Yeah. For somebody who's got an abnormal baby, say either a severe Downs or an anencephaly baby, or, you know, a massive spina bifida, and, you know, often picked up just a little bit later, say they are 20 or so weeks, what kind of support is available to them? And, you know, I'm presuming they labour out their normal little baby. Do they get some mementos? Can they say goodbye to it? Is it kind of a bit more like a labour?
Yeah. King Edward does most of those late terminations, and they provide a superb service in terms of support, both pre-procedure and post-procedure. The labour is not like a normal labour in that there's not a discrete sequence of events of getting into the pattern of regular contractions and then
monitoring
all of that sort of thing, followed by pushing. It tends to happen quite suddenly. They'll have medication, 8 hours or 6 hours will go by, they'll have some more, all of a sudden they may have a lot of contractions and deliver quite rapidly. So it's not quite the same as a normal labour, and it may take them a little by surprise, the intensity of it all.
Often you have a retained placenta as well. So
risk of retained placenta is about 50%, so they will be, they need to be made aware of that, so that if that happens and the trip to theatre for a manual removal occurs, it's not yet another shocking thing. They've heard about it, they've understood. The other thing that needs to be discussed with them beforehand, and the midwives are usually excellent at doing this, is broaching the topic of what's going to happen to the baby as soon as it's delivered. Is it going to be taken away and cleaned up and wrapped up by the midwife for the parents to view later on? Do they want the baby put on mum's tummy like at a normal delivery? What do they actually want to happen? And often people are undecided. They say, we'll see how it goes, and the midwives are really good at gauging the mood. Sometimes they say, we'll take the baby away, wrap him or her up, and especially if the baby's very deformed, they may choose just to look at the face initially, and then if they're curious, unwrap the child. Pastoral support's widely available. Mementos such as hand and footprints, cards, the little armbandy thing, are all made up into a book, if the patient so desires. So
and you can have cremations or burials. So King Edward offer a cremation service, and you can have the ashes put in the rose garden at King Edward, or you can take the ashes and put them wherever you like, or you can arrange for burials.
So you can have a proper funeral for what is essentially your baby, even if it was pretty much stillborn. Is this service available in any regional centre, or if somebody is in this situation, would they have to come down to King Edward's?
Have to come to King Edward's.
I don't think Bunbury does any.
No.
So that really would be quite thinking of somebody from the Kimberley, that would be very traumatic, wouldn't it, in terms of distance from family and stuff.
Yeah.
Narelle, welcome to the program.
Thank you, Olga. Nice to be here.
Could we talk about ovulation tracking? It seems to be the big thing these days, especially for our IVF patients. But how's it best used?
Okay, well, I think ovulation tracking is probably best used for people who've got regular cycles or regular periods to start with. It's probably not the first test to do in somebody who's got very irregular periods or episodes of amenorrhea.
Mm-hmm.
So in those women, I think there would be a better set of investigations. But if a lady has got regular cycles and is anxious to get pregnant, probably before I did ovulation tracking, I'd do a day 21 progesterone, which is working out how long the lady's cycle is, counting back a week, and then doing a progesterone, just to see whether she's ovulating or not. That would be the first step.
So that would be assuming a 28-day cycle.
Yeah.
With day 1 of the cycle being the first day of the period.
Exactly right.
And so you count 21 up from the first day of the last period, or do you count 7 back from the predicted day if they've got a longer cycle?
You can do either, of course, but the most accurate way to do it is if the cycle's regular, and let's say it's 35 days, yes, count back 7 days and say, okay, on day 28 of cycle, we're going to do a progesterone. And that's when we expect that the peak highest progesterone will occur. And we're looking for a value 20 or 30, at least over 20, to confirm that ovulation did occur. And if it's 30, then that sort of helps us be satisfied that there's an adequate luteal phase.
Okay, so given that it's a quite an intense process, about how long of trying would you let the women go before you said, okay, perhaps we should track this and see whether you're ovulating?
Yeah, I guess that's very individual. The definition of infertility, of course, is a year of trying with unprotected intercourse and still not being able to fall pregnant. So certainly women who've been trying for a year, we would think this may be very helpful if they've got regular cycles, as we stressed at the beginning. But in women who are older, you know, somebody who's perhaps in their mid to late 30s, or even a woman who's older than that, they may not want to spend a year trying before they go to ovulation tracking. So I think it is very individual, and someone should come and have a chat to their GP.
Yeah. Okay, so could you run us through just the basic hormone changes that happen during a cycle so that we can see what we're looking for?
Sure, I think that's a really helpful place to start. So to start with, I've got a diagram here that's got some different coloured lines on it, and the first line you can see is the blue line, and that is the LH hormone that goes along just steadily and then surges up in the middle to a sharp peak. That's the main ovulatory hormone, and we look for the LH surge. At the same time, you can see a pink line, which is gradually increasing and coming up like a wave almost and cresting just before that LH peak. That's the oestrogen level. So those are the two main hormones we're looking at in ovulation tracking. And then the third line you can see, which is the green one, is progesterone. That should be low, and we should get low levels, 2s, 3s, something like that, until a lady's ovulated. And then a week afterwards, when we were talking about doing that luteal phase progesterone, is when we would expect to see a nice high progesterone.
And that's sort of 25, 30?
Yeah, that's right. 20 to 30 would be what we'd expect. So that's what hormones look like in a nice pretty diagram. But I guess the next thing to look at is what do they look at like in numbers when you get results back from us at the lab.
Yep.
And here I've got some examples of what happens. So going down the left-hand side of the page, I've got the day of cycle. And then just to show you that FSH itself, that column of values, FSH goes up slightly at mid-cycle, hence why we don't want to get a mid-cycle FSH and we try and do a day 2, 3 level, so that's when it's lowest. Then as we talked about E2, you can see those numbers going from 400, 760 up to 1,300 peaking. That's when we'd be looking to see what's happening with LH, and you can see...
And that's a normal kind of peak level if a woman's going to ovulate?
It's very variable. Everyone sort of asks me, the ladies I track, what's a normal oestrogen? It's different for every woman, but generally something sort of from 500 up will be adequate for most people to ovulate. So it might be 500 for one, 1,000 for another, but somewhere in that range upwards. Yep. A rough rule of thumb is 1,000 is equal to about 1 egg, 2,000 picomole per litre, 2 eggs, and so on. So, you know, if you see a level of about 4,000, you might think, gosh, that's 4 eggs about to ovulate. Perhaps we won't tell this lady to try.
Yeah.
So just a bit of a sort of guide to you. So looking at that oestrogen level coming up, and at the same time then watching the LH numbers, and those will come up just into the teens and then rapidly rise. You'll get a sharp peak to numbers, anything 20, 30, 50 even. That's the surge. That's when we ring the lady up and say, time to try for a pregnancy. This day and the next day to give them the best chance of fertility.
Do you have any examples of women, say, with very short cycles or long cycles so that we can see what's happening?
I do. So, for example, on these results, I've got the LH, you can see gradually going from 6 to 10 and then suddenly rising up to 56 with the oestrogen then at 910. That's the day we'd tell that lady to try for a pregnancy, on day 10 and day 11. And on the next set of results I've got for you, you can see that it takes slightly longer to get to ovulation. Once again, LH is rising up. You see it hits 13. The next day, bang, it's up to 29. And at the same time, oestrogen is in a nice high range. So those results there in red would be the day I'd say for that lady to try for a pregnancy.
Yeah. Narelle, do you ever get any results that kind of wave a red flag and say to you, gosh, there's something not right happening here or something not normal?
Yes, I guess the most common worrying set of results we'd see is perhaps when a lady gets a little overstimulated. So clomiphene or Clomid is not uncommonly used, and I guess it's important to get the dose right. If I see somebody who's on a bit much clomiphene, as in this current example I've got here to show you, you can see that the oestrogens are already starting out quite high. They're sort of in the range of 2,000. They go up to 3,000, 4,000. As we mentioned, that means 3 or 4 eggs, and by the time this lady ovulates, we're looking at an oestrogen of 6,000. That's worrying on a number of levels, obviously. That's a massive oestrogen. The lady's in danger of becoming hyperstimulated with fluid retention. You know, you can get ascites, peripheral edema, cardiac complications, all sorts of things, let alone the fact that there's 6 eggs ovulating, and really who wants to end up with sextuplets or, you know, so this would be a set of results where I would be contacting the clinician urgently saying, listen, we need to keep a close eye on this lady. And obviously next time we would not be wanting to see her have so much Clomid.
Yep. What does the lab provide in terms of ringing patients and following up results, and how much of this is done by, say, the fertility clinic that's providing the clomiphene, and how much is done by the GP?
Well, it's very variable, and certainly lots of labs can offer quite a good deal of support. At one of the labs I work at, we certainly manage the patients, direct them to do the blood tests as needed every day or second daily. We'll ring them every day with results, tell them when to try for a pregnancy, etc. Keep an eye on the results. Certainly we liaise with the GPs and send copies back to them continually, and then they will advise us if they want the lady to have another cycle or not. In the country setting, obviously it's a bit more difficult. We've got the tyranny of distance, and getting access to tests and getting a result back in a timely fashion is a lot harder. But I think all I'd say is talk to your local lab, whoever they may be, find out who the pathologists are and have a quick chat to them. And most labs are able to help you. Even if you're running a day behind, when you're used to looking at lots of hormones, you can still sometimes preempt and predict, okay, I think tomorrow is going to be ovulation, even though I haven't quite got the results in front of me yet.
Thanks to Dr. Hadlow for taking the time to speak to us. Now let's return to the discussion with Olga Ward, Dr. Susan Downs and Dr. Robyn Leake.
Well, can we hit another controversial subject while we're on controversial subjects? Caesarean sections occasionally pop up in the newspaper. Why do we do so many caesarean sections, and is it really a problem?
Right.
Are we looking to punt this question to each other, are we?
Why? I think you've got to, it breaks down into 2 groups, really. Who wants the caesarean? Does the mother want the caesarean, or does the doctor want the caesarean? And certainly in private hospitals and in private care, caesareans are far greater than in the public hospitals and public care. Is that because the 2 populations that attend those different people are different? You could say that women that go to private consultants are probably maybe older women that have planned their life and have got a life, and both the private doctor and the businesswoman want to have caesareans for the ease of management of the rest of their lives.
Doesn't sound very easy to me, though. A very large scar and a very large baby well, even a normal-sized baby to hump around with an abdominal scar sounds quite difficult. You
could say also that private consultants see a lot of problems. You know, because that's why they're consultants, so they see more problematic pregnancies, and therefore more problematic pregnancies would need a caesarean more frequently, so that's why they have a higher rate. Certainly in my GP obstetrics, and I do caesareans, my personal caesarean rate is very low, but then I do a lot of watch and wait and monitoring, and probably my forceps and vacuum rate are higher. And with my experience, I feel confident doing that, and then I always know that we can convert to a caesarean very quickly from where we are, because we've got the facilities right just down the corridor.
Yeah. Robyn, is there a huge amount of controversy amongst obstetricians about this, or are they all pretty comfortable with what's happening in Western Australia?
I think a bit of both.
Yep.
Some people are comfortable with the service that they offer and the clientele to whom they offer it. Others, do feel concerns. The main problem, well, one of the main significantly morbid and possibly mortal problems after caesarean is the higher incidence of abnormal placentation, so placenta accreta and that sort of thing, which goes up markedly with previous caesarean sections, because that's a potentially life-threatening circumstance for mother and baby, but especially mother. And we're seeing more of those, and that concerns everyone. I think everyone is a little bit concerned.
So that's your main problem that you would see with a high caesarean rate?
Well, certainly the most...
Repeated caesareans in the same woman.
That's right. It's certainly the most frightening.
Yeah.
Basically, if you want to keep the caesarean rate down, you need to stop the first ones. Once women have had their first caesarean section, not very many folks go for a VBAC, so vaginal birth after caesarean section. If you really want to prevent caesars, you've got to prevent the first one.
Yeah.
And I think the other thing too is, as women are becoming older, having babies at an older age, they are bringing with them more medical problems, more diabetes, more obesity, more hypertension. And I think those factors do contribute to the high caesarean section rate. And those folks probably are slightly more biased to the private sector as a generalisation.
Do GP obstetricians try out the what we used to call trial of SCAR? And
yeah, we do. VBAC? We do vaginal deliveries post-Caesar at Derby and Broome and Kununurra and the other Pilbara hospitals. Yep, it depends on obviously why the first Caesar was, how much you would recommend that we give it a trial. If it was for for a huge baby, if it was for a breech first and this one's cephalic, obviously you go for it.
Yeah.
If it was because of CPD previously and then you've got a baby that's even bigger this time,
maybe not.
Maybe not. Yeah. So it's mostly fairly easy to say, and the chances of delivery depend on what the previous one, of successful vaginal delivery depend on what the previous cause was.
Yeah.
And if the woman's laboured before and then perhaps had fetal distress, she's even more likely to have a successful VBAC because the uterus has done its thing before. It was interrupted,
but it had a shot at it. Yeah. And I suppose a kind of a more wheat belt problem. Are we doing any harm inducing labour with rural patients who have no local obstetric services, which I have to say is a large sector of the central wheat belt? And
so you mean you're sending them?
You send them to Perth,
and they don't want to go
you punt them out at 36 weeks because you don't want them to pop on site, although occasionally they do. And then they've got to hang around in, a regional centre, Perth, Kalgoorlie, Narrogin, Northam, for however long it takes for them to go into labour. And quite a number of women will sort of say, look, I can't afford 4 weeks in Perth with my husband working on the farm and three other kids in tow.
We have the same problem with distant Aboriginal communities coming into Derby, and they're meant to be there at 36, 37 weeks and hang around for the delivery, and they've left 3 kids at home, etc.
Yeah.
What do? I see them weekly, and I offer them a vaginal stretch and sweep, so I do a vaginal examination and try and get that right. Our induction rate is probably low because of that. Midwives can do that as well. And I wouldn't induce anybody that the cervix wasn't right, unless for post-aids, unless they had some other diabetes or other renal failure or problems that were going to affect the baby. We also do CTGs post-dates as well.
Yeah. You do occasionally get patients coming back and saying, oh, the specialist said he would induce me at 39 weeks so that I wouldn't have to hang around, as long as my cervix is all right.
Yes, as long as your cervix is all right.
And that's the big proviso, isn't it?
It is, definitely, because certainly there's more instrumental deliveries and more caesareans on women that have had an inappropriate induction.
Well, the patient's tootled off to Perth, popped out the baby, picked up the baby and their 3 other toddlers and trottled back to your local rural community. Those first few postpartum days, quite scary if you don't, because a lot of rural communities don't have midwives on site. No. And so quite often it's just, the doctor and the practice nurse and the nurses at the hospital who are going, oh my God, it's obstetrics, hands off.
Well, the turnover in Perth hospitals, Kalia and King Edward, is quite high. Women are going out on day 2 and having the home midwifery service visit them, which is obviously not available.
So they show up back on the farm. What are the traps for unwary players?
Well, they are asked to try and stay around so that they can be visited for 5 days, but most people from the country don't want to do that. They want to get out as soon as they possibly can. You've got to watch for bleeding. You've got to watch for postnatal depression, those 2 things in particular.
Yep. How much bleeding is too much?
Women expect, or you expect the women that will bleed maybe for a week or 2, and then it should gradually be getting less. If they've stopped bleeding and then it restarts, that's more of a concern.
Like if somebody says to you, I'm getting a lot of clots and I'm changing a pad every hour, is that unreasonable?
That sounds unreasonable.
That sounds unreasonable to me. Yeah.
Yeah. And the biggest thing you would think, is there any retained products here?
Yeah.
Yep. And infections.
Or infections.
Yeah. So how would you deal with that in a rural community with pretty basic facilities and occasional ultrasound?
Well, I would do an ultrasound to see whether there was anything there. I would certainly take swabs, and I would probably treat them with antibiotics anyway.
Can you talk about postnatal depression and practical screening for this?
Some people use the Edinburgh postnatal depression scale. They use that both antenatally and on a number of occasions, and postnatally, and they look at the trends of those things. But really, I just ask people how are they feeling, how are they coping, and if they suddenly break down and cry, which they often do, then you have to look at why is they doing that. Is it just they've got too many kids around, or can somebody help them? And look for practical things as well. I don't immediately reach for the script pad and for an antidepressant, but you look for supportive things. 1 in 10 women are going to get postnatal depression, probably more get postnatal anxiety and low moods. And it's a very hard thing to cope with a young baby on your boob and with 3 others, and you're trying to run a farm and all those other things.
Yeah. What happens for your patients out at Walloona, Robyn? What kind of supports are out there?
There's an excellent AMS with excellent general practitioners and nursing staff. There are some Aboriginal health workers as well. The psychologist visits, I can't tell you the interval of visit, but it's, I believe, reasonably frequently.
So if you found a woman with severe postnatal depression, or even moderate postnatal depression, there's still some professional support even in a very remote community.
If it were me seeing her, I would, before I left town, hand her over to the GP and say, look, I've seen this lady and these are the problems and you need to keep an eye on.
I think it's less, postnatal depression is less in Aboriginal, from my experience, because they've got such extended families and such experience. They grow up seeing babies at the breast all the time. Lots of kids, 9-year-olds look after 3 other babies and that sort of thing. So they know about babies. They have lots of aunts and grandmas and things that all do help out with this baby. And I think
So really it's more the isolated non-Indigenous
Yes.
women who
Yeah.
fall in
And
a
more-
hole, particularly I'm thinking about mining communities
Yes.
where extended family is not there, and
the teachers and the nurses that
the dads are
go back, and the police wives that go back to these places, they're more at risk than the Indigenous women.
Yeah. Are there any particular postpartum or postnatal issues that you do see in Indigenous women that are perhaps more typical?
Possibly infection.
Yeah.
Lack of contraception as well.
Yep. So you have to jump on that fairly
Yeah.
quickly. What sort of infections do you see?
Well, the STIs in particular.
So that's something that's maybe been around through the whole pregnancy and is now causing a
Well,
problem, or it's
you
just
have-
something
you
that they
have-
pick up very early in?
You have great screening during pregnancy. You know, we're doing screening for STIs at their first visit at 36 weeks, and often, you know, ruptured membranes, or we screen again. We even screen for syphilis routinely with a blood test at 36 weeks in the Kimberley as well, which you don't do down here as far as I know.
You just do it at initial
Yes,
antenatal screen.
And so by the time they've got home, they've been away for 4 weeks or so waiting for the baby. By the time they get home, there's often a lot of early sex and infections.
Well, listen, we've covered a lot of topics today. Do you have any final comments or take-home messages?
I think pre-pregnancy counselling and awareness is the big thing. And then once you've seeded with all the things that you can prevent and discuss things before pregnancy, then you're more likely to be able to follow the events of pregnancy. I think the most important thing that any teacher or any doctor can teach any teenage girl is to think about when her periods come and to remember when that last menstrual period was, because time is totally not there. When did you last have sex? Last football match. When was your last period? Oh, I don't know. And you put the speculum in, and they're obviously having one right this minute. They don't think about the timing of things, and in medicine, and especially obstetrics, timing is so important. Timing of conception, dating ultrasounds. I personally have a backpack ultrasound, so I date everybody, and they've got good dating, but most people would miss out on that if that wasn't available. And the dating ultrasound means, can you have the nuchal fold test at the right time? Can you have the
16-week.
the 16-week test at the right time? Can you have the 20-week 18 to 20-week morphology scan at the right time? And especially right at the end, have they got the right gestation so that they know that they're 36 weeks to go to town, instead of being an RFS fly-out in labour because they thought they were 36 weeks but they were actually 30, 39, 40. So dating scans, but remember your last menstrual period and be aware of your cycle. Because you say to people, what's your cycle like? Does it come regularly? Yes. When was your last period?
Don't know.
4 moons ago. You know, it's very difficult. They just don't. But if you teach them that at school and get them to have a calendar or a mobile phone or something that you tick the time off, that would make my job very much easier.
And Robyn?
No, I think that's really important. The correct dating saves so much time and money later on. If you think about the potential for one of the implications of doing a 16-week blood test and getting the dates wrong is you'll get a false result.
Yes.
You'll be higher risk if you've done it too early.
Or arranging for somebody to go for a morphology scan when they're only 16 weeks.
The money that's wasted.
The money that's wasted, getting them there, the effort and money getting them there, and then
it's
having
the
to
wrong
come back
time.
in a month's time or 2 weeks' time. Yeah.
Terrific. Well, thanks for joining us, and
Thank you.
it's been a great program. Thank you.
Thank you.
Well, finally tonight, Jean Hales is an organisation dedicated to promoting women's health. Carolyn Wall, Coordinator of Health Professional Education at Jean Hales, spoke to us about the online resources available to support GPs in managing women's health.
Jean Hales for Women's Health is a national not-for-profit women's health organisation. We're based in Clayton, Victoria, and comprise a research unit, a medical centre and an education unit. We run various health professional activities from our site in Clayton. We have a national seminar program which does reach across to rural and remote Australia. We also provide a supervised clinical attachment program based in Clayton, and we have ad hoc health professional education sessions, a webcast program and online activities. We currently have 3 active learning modules on our website: prescribing hormone therapy, osteoporosis and diagnosis and management of PCOS. All of these topics take approximately 6.5 to 7 hours to complete each ALM. They're accredited with the RACGP with women's health points, and they're all with 40 Category 1 points. We have 14 webcasts also available on our website for people to view. These activities also attract points, and all of the activities available on our website are free of charge. Our clinical attachment program is run through our medical centre in Clayton. HPs and GPs are invited to apply to attend these sessions. Generally, it's a case of attending for 3 sessions with clinicians of your choosing. We have gynecologists, endocrinologists, women's health GPs, physiotherapists, and you sit in with those supervisors and complete an attachment. They take 10 hours to complete and also attract Category 1 points through the RACGP. For all of the activities I've spoken about today, you can contact myself at the Foundation, Carolyn.Wall @genehales.org.au, or our toll-free number, which is 1800-GENE-HALES. Our website is www.genehales.org.au.
And thanks to all our guests, Dr. Susan Downs, Dr. Robyn Leake, Dr. Narelle Hadlow, and our own Dr. Olga Ward for their time. And a reminder to you, if you'd like to consider further continuing professional development in women's health, Rural Health West has a number of programs related specifically to this topic. They are supervised clinical attachments in obstetrics, GP obstetric mentoring program, and obstetrics and frontline gynecology workshops. Further information regarding all of these programs can be found by visiting the Rural Health West website at ruralhealthwest.com.au. I'm Jerry Gannon. On behalf of all of us here, thanks for joining us.